Hyperkalemia in the ED is a big deal for me. Immediately on these patients, I'm getting an EKG and a VBG with lights because I want to know as soon as I can what that potassium is so I can start working to shift. In theory, you can act if the potassium is greater than 6.5 or if you see EKG changes, a rapid rise, or the patient's symptomatic. So the first step is going to be stabilizing the heart, and we do this with IV calcium. Why do we give calcium in hyperkalemia? Weird, right? Hyperkalemia makes cardiac cells more excitable by lowering the threshold for depolarization. Calcium doesn't lower potassium, it stabilizes the cardiac membrane, buying time until you can shift or remove potassium. So how do we give it? There are two options. Calcium gluconate is preferred if you're giving it peripherally. I give 1 to 3 grams IV over 2 to 5 minutes. It acts in 1 to 3 minutes and it lasts about 30 to 60 minutes. So you buy yourself about an hour of time. This is safer for the peripheral IV because there's less risk of tissue necrosis if extravasation happens. And then calcium chloride is stronger because it has 3 times more elemental calcium than gluconate. I give 1 gram and this is over 2 to 5 minutes. Onset is immediate and this is so much more potent. This should be given through a central line because it causes severe necrosis if it extravasates. Shifting potassium into your cells is going to be your next step. So the way that you can do this is with insulin and glucose. This drives potassium into the cells. You can also give an albuterol neb, like a beta-2 agonist that drives the potassium in. You can give bicarb if they're acidotic. And then finally, you want to think about removing the potassium. You can do this with a loop diuretic if they're making urine, but a lot of these patients are ESRD and they're on dialysis. You can also give K-Xlate. K-Xlate takes quite a while. So usually I'm not doing this in the ER because it's really not going to help stabilize these patients. Hemodialysis is definitive care in ESRD in severe cases. So always be thinking about calling nephrology early. Looking at the EKG is really important. So EKG changes that you act on immediately would be peak T waves, QRS widening, or a sine wave.